And I'm going to hand the floor over to Matthieu when you're ready.
Yeah, thank you. So it's the most dangerous time of the workshop because it's a post-lunch coma, so I will try to kick off the drowsiness. And let's talk about scales and machine learning algorithms. The objective is to draw an overview of what exists about scales and machine learning to identify palliative care needs, and also the risk of complication in non-curable patients. But I won't be able to talk about all what it exists, so I choose some specific example to illustrate what is possible in this area. So I will first introduce some general comparison between the different kind of models existing in machine learning to understand how this algorithms works. And after I will present some example about machine learning models predicting mortality, because it was the first step of predicting palliative care. And after I will give you an example about a specific algorithm for palliative care needs. And then we will move on different scales existing to identify needs of palliative care. First, general palliative care needs, and after, more specialized palliative care. So let's go. If we are talking about this today, is because identifying palliative care needs is a very critical aspect during the healthcare pathway of our patients. So we know there is various scales to improve accuracy and timeliness of identification of needs. And recently, machine learning has been developed with most effort focused on prognostication. So these predictive models have been developed to forecast outcomes such as short-term mortality. Most of them are dedicated to this. But also needs for specialized palliative care referral, or, for example, hospital or emergency department utilization, or clinical events like death or other complications. The objective today, as I said to you, is to provide a comprehensive overview of what exists in this area. So first, what are we talking about when we are talking about machine learning? We are talking about different kind of technology. We can have a first step of machine learning with elastic net logistic regression. It's just statistical models with regularization techniques to avoid the fact to overfit, so to be too specific with data used to train the models. It's a first step, because a better way to use machine learning is to use random forest. It can be described as mini decision trees, and each tree gives a vote, and the final answer is based on the majority of the vote. The strength is this is a stable technology with few errors for each individual trees. More developed thing is also a gradient boosting. It's like models built step by step. Each mini models, this is usually one decision tree, the models, tries to fix the mistakes of the previous ones. So it's a step more developed than the random forest. And there exists also gradient boosting optimized for speed and accuracy. The strength is that these models often perform better and faster answers than random forest technology. And the last step is what we can, when we want to, what we are speaking about when we are talking about deep learning. This is a special kind of deep learning inspired by the human being and human brain. This time-based data, this is something able to forecast how the patient health will change day after day. And the strength is a great to handle with large data and tracking patterns over time. So what this is how this machine learning works, you know. So we are not talking about only one kind of models. We are talking about different kind of technologies. And we can compare these technologies by the complexity and the possibility to interpret and the performance. And we have a gradient from low complexity to very high, crescent gradient for the different kind of technology I introduced to you. And the other side of the coin is the most the model is complex, the less is interpretable, and with the less we know how it is working. But the performance is the best performance is for the deep learning, and this is what is ongoing for the development currently, is to use more and more deep learning when we can. But we will see that less developed system may be accurate also. So this is the post-lunch thing. So now let's have more example of that. The first model of machine learning developed to predict palliative care actually were developed to predict mortality and the risk of mortality. And this is, for example, what did a gradient boost machine learning model on patients with cancer. I wrote to you as a related reference. And it was trained on electronic health data. And it was to predict the mortality after the chemotherapy beginning. And it was highly discriminant, and it was accurate for that. We also, some teams also developed models for patients with dementia, donc it's not only for patients with cancer. It was a neural network, so it was deep learning model incorporating and also in the same time structured. Structured is something you know, to know which kind of service the patient was addressed, and unstructured data, which is more clinical data. And it was with deep learning, as you saw. And it was also very accurate to predict mortality. And this is, you know, the strength of deep learning. You can have accuracy all along the healthcare pathway in the time. So this is interest. The conclusion of this example is there is interest in machine learning to mix different kind of data. Some data from the patient. It was real-world data, you know, clinical one, and traditional prognostic indices, for example, some scales in the model. So mortality was one also an objective to be predicted in non-specific population. So some models have been developed in more general population, and it was more difficult because this is a more various heterogeneity of the characteristic of the patients. And for that, deep learning is also very good because it can handle with big data and very different kind of data. And it was used to develop a model to predict the probability of death, also mortality again, of a given hospital. So it was very local prediction. And this is also a very accurate performance. And also the mistake were also interesting because there is a lot of false positive, meaning the patient predicted to die but who survived finally beyond a year. And this kind of patients are also interesting to be seen by a specialized palliative care team, actually. So the model flag patients with likely serious needs, even if they do not die within the time frame they were supposed to do. So this is finally a good thing to have models to predict mortality, even when they are not completely accurate. if we use this outcome in the objective to identify patients who need palliative care. It was also another kind of model developed for multiple chronic conditions. This time it was applied to administrative data, and it was a less developed technology because it was a boost, at a boost ensemble. But in the interest of this example, if this is a challenge to predict mortality in heterogeneous population, if we use only one kind of data. This is the conclusion of this, because you saw that the accuracy of this model is less interesting. Okay. I gave you a last example of models predicting mortality because this model developed by Mentz and al. In 2020 was an integrated algorithm also on electronic data, but it was predicting long-last mortality because it was 3 months modality, sorry, for all cancer patients, outpatients. And the interest of this one is the accuracy is closely matching its retrospective performance, meaning that he has been developed retrospectively, sorry, and also prospectively. And this is one of the unique model validate prospectively. This is often a critic we have on these models. They are validated on retrospective data, and they are not validated in routine. So this one is not the case. It was a last example of model predicting mortality. And as I told you, there is now a challenge to directly predict the palliative care needs, not only by the fact to predict mortality. And recently, the Mayo Clinic in the US presented at the LASCO conference AI-driven palliative care models specifically dedicated to predict referral for hospitalized patients to palliative care, specialized palliative care. It was validated in a randomized trial with a highly significant difference to predict to identify the patient who needs the palliative care consultation, and it also showed that it reduced hospitalization. So I just indicated to you the key variables on which this models is based. Some previous specialized palliative care visits, age, metastatic disease, and pain score. So this is interesting models to follow. I would see it will evolve in the next years, I think. So a last example of predicting palliative care this time is a model used deep learning. In conclusion, this model have shown promise to predict mortality and also to identify patients who could benefit from palliative care. And it was also validated on a mix of data on electronic health record and combining claims and real-world data. So, models to predict referral and needs, similar to mortality models. I show you 3 based ensembles, one of random forest, one of gradient boosted machine, and one on deep learning technology to flag patients with high risk for palliative care needs. But simpler approaches can be effective. For example, I show you a rule-based trigger based on only age, comorbidity, and the fact to be hospitalized in the last 6 months. Has showed a good prediction for mortality risk and is as effective as some machine learning models also. So this is something to keep in mind. The technology is good, but maybe we can also do easier. Okay. So let's focus now on some example of scales. This is a more older story to develop scales to identifying needs in palliative care. First, scales has been developed to identify needs of general palliative care, to identify the patient in palliative situation. They look for changes in health, increasing burden of illness and more care needs. And they are designed for clinicians working in primary or secondary care and to identify their patient at risk of dying and likely to benefit for general palliative care. So the assessment generally are based on clinical observation, performance status, symptoms, multimorbidity, illness trajectory, and also the perspective given by the patients. The first example of these scales is supportive and palliative care indicators tools, PICS. The benefit of these scales is there is a lot of translation, so we can use it in, the first one was from an English team, but it's also translated into French and Spanish, and the list is almost 10 or 11 languages. So this is useful, and as you see on the slide, it is designed for the primary caregivers, non-specialists on palliative care. So it's a good tools to spread in ambulatory care and to identify different kind of population in palliative situation. And the other level is to identify among these patients who will be in needs of specialized palliative care to be referred to this specialist team. And there is a lot of scales developed on this topic based on the complexity in palliative care. This is a large concept with there is different concept defining what is complicated in palliative care and in need of specialized team. So all the scales developed to identify the patient who needs specialized palliative care are based on the same kind of characteristic. There is some domain related to patient and family, and also some domain related to the interventions. This complexity is commonly characterized by the number and the severity of domain involved and the interaction between the domains. And so one example is the PALCOM palliative care complexity model. It has been developed for advanced care patients. It's based on the assessment of 5 domains, multidimensional symptoms, including pain, performance status, socio-familial risk, and existential issue. And it classifies the complexity of palliative care needs into 3 levels. The first level brings to identify patient who is not necessarily needed specialized palliative care. The second level, with a score of 2 or 3, leads to a medium complexity, recommending shared care with specialized palliative care. And the last level recommend intense care by specialized team. So this is what PALCOM looks like. And you have also the references. I also introduced to you a second example of scale, identifying patient who needs specialized palliative care, with this time 35 items in 3 dimensions: patient, family, health care organization. each item is classified as either complex or highly complex, and it can be administered by non-specialized healthcare professional also, but it's not a PROM, it's not a patient-reported outcome. This is the health giver who is conducting the EDC part. So it classifies also into 3 stages of complexity with the same kind of results, you know. And it's better if you know the situation about the patient for at least 3 days before assessing the level of complexity with these scales. So it's not a tool used for acute situation, you know. It's something to identify chronic situation needed specialized care. You can see on this slide the scales, the EDC pearl, with the 35 items and the complexity level related to each item. And the last example is the scale named Integrated Palliative Care Outcome Scale. Almost the same number of items grouped also in 3 domains: patient, family, and professional healthcare system. And there is, among these 36 items, 22 of complexity and 14 of high complexity. And in the same way, you can have 3 grades of complexity, depending if you have no item of complexity of high complexity, or at least 1 item of complexity, or at least 1 item of high complexity. And the recommendation about the referral depends on the grade of complexity. The IPOs looks like this scale. So, to conclude, we saw that the integration of machine learning algorithms and scale can improve the identification of palliative care needs. And if you remember what we said this morning, it was one of the challenges identified by health professionals and by patients and relatives to predict the needs and to identify very early in the healthcare pathway the needs. So these scales should be probably implemented in the routine or maybe in the digital tools we are talking about to standardize the way to identify the situation needed specialized palliative care. The algorithms you saw that such as gradient boosting, random forest, or deep learning models have demonstrated high accuracy in predicting patient outcome, but the scales stay very useful in clinical routine and more available for the routine use. These tools support clinicians in making data-driven decision, and to improve the timeliness. This is the most challenging thing in the healthcare pathway of palliative care intervention, and in the order to enhance the patient outcomes and the quality of care. Thank you for attention.